Good afternoon, respected teachers and my dear colleagues. Now I am going to present an interesting case of chest discomfort. My patient is a 56-year-old male from Kharagpur. He presented with swelling of both legs since 8 days, breathlessness in recumbent position since 5 days, and distension of abdomen in 5 days. Elaborating the chief complaints, the swelling of both legs was gradually progressive, and 2 days later he felt suffocating type of discomfort over the precordium, which was mild to moderate, continuous, gradually progressive, increase in lying down position, and there was no diurnal variation. The distension of abdomen was generalized and not associated with pain. Coming to the past history, the patient is not a known case of hypertension, coughs, or bronchial asthma. He has been suffering from 15 years with type 2 diabetes mellitus. He had an episode of anterior wall myocardial infarction in April 2005 and underwent coronary angiography in which showed double vessel disease. He was operated for CABG in 2007. Coming to the personal history, the patient is married, has one son. There was no history of sexual promiscuity. He was a chronic smoker for 15 years and left smoking since 2005. He is a non-alcoholic, non-vegetarian, appetite, bowel and bladder habits were normal. There was no history of diabetes mellitus, hypertension, coughs or ischemic heart disease in the family. Coming to the general examination, the patient was conscious, alert and oriented. He was of normal build. There was no pallor, inferior cyanosis, clubbing or lymphadenopathy. The pedal edema was bilateral and of picking type. The JVP was not raised. Pulse and BP were found to be within normal limits. The patient was afebrile and the respiratory rate was found to be normal. Coming to the inspection of the cardiovascular system, over the precordium, the shape of the precordium was normal. There were no abnormal pulsations or engorged superficial veins, and midline sternals comma plus C. There was no scoliosis, kyphosis, winging of scapula or drooping of shoulder. Coming to palpation, in the mitral area, the apex field was palpable in the left fifth intercostal space, 1 cm median to the mid-clavicular line. There were no thrills palpable. There was no left parasternal view and no thrills in the tricuspid area. There were no abnormal pulsations or thrills in the aortic and pulmonary areas. Likewise, there were no pulsations in the epigastric and suprasternal areas. The trachea was centrally in position. Coming to the auscultation, S1 and S2, the first and second heart sounds were faintly heard. There was no S3 or S4, no murmurs were heard. There was no carotid body or pericardial rub. Coming to the inspection of the respiratory system, the respiratory movements were equal on both sides. On palpation, the trachea was centrally in position and the respiratory movements were equal bilaterally. The percussion and auscultation of the respiratory system revealed normal findings. The examination of the GIT, nervous system and locomotor system revealed normal findings. To summarize my case, the patient was a 56-year-old male who was a chronic ex-smoker and a diabetic. He underwent CABG and presented with chest discomfort, swelling of feet, breathlessness in lying down or recumbent position and generalized distension of abdomen. The examination revealed mild edema, faint S1, S2 and there were no significant murmurs.
Now case is open to house.
Yes, I think 56-year male chronic. I think the problem is the patient underwent CABG, supposed to have a good quality of life, but even in spite of that, the patient had breathlessness, he has got edema, etc. So I think perhaps I just think of some cardiomyopathy, like ischemic cardiomyopathy, because that is the even the radioactive nucleotide states can give some idea about the viability of the cardiac muscles. Patient is diabetic, Professor Banerjee is here. I don't know whether it has got in relation to diabetic cardiomyopathy also, because that can, of course, for that reason you have to do some biopsy. Patient is having congestive cardiac failure, both biventricular, the patient has referred. So I think there are two possibilities: ischemic cardiomyopathy and diabetic cardiomyopathy.
Thank you, sir.
Patient is a very well healthy, he is a RPF man, so he is a very powerful, having robust personality. But whole problem is started in this post CABG was done 37, and this time he admitted with a absolutely in the dying position. I am dying every day, not able to even the dyspnea severe in the bed. He was rolling, I was in very much agony with some investigation outside admitted. This whole story was a very. We have come good.
Can you comment about the JVP?
Yeah, JVP is right-sided. Right-sided JVP is slightly raised with edema, appendicitis, and whole thing. So CCF picture, just like I was writing in early male thoughts with the CCF in a background of whole CCF. So we have next. Yeah. Whole thing is the with picture and investigation. Next. Exactly. Absolutely. In that round, we have, because clinically I am only one single finding that our S1, S2 sound is very faint, and we are not able to do this with CCF. So keep in mind for that.
Coming to the possibilities, there are three possibilities: diabetes mellitus with post CABG with congestive cardiac failure. The other possibility was a restenosis, that is a graft blockage and congestive cardiac failure, and the third possibility was pericardial effusion.
So our CCF restenosis and these three we have kept in mind, including this following investigation.
Coming to the investigations, the blood test, that is hemoglobin, total leukocyte count, the differential leukocyte count, platelet count, and ESR were found to be within normal limits. The blood sugar parameters were found to be within normal limits. The RFT parameters were found to be within normal limits. The liver function tests were found to be within normal limits. The lipid profile was found to be normal. Serum LDH and serum CKMB were found to be normal. Coming to the picture of the chest X-ray, the cardiothoracic ratio was found to be increased. The costophrenic angles were clear, but there was cardiomegaly. Coming to the ECG, there was normal sinus rhythm 80 per minute. There was T inversion in leads 1, 2, 3, AVF, V5 to V6. This is the picture of the ECG of the patient. An ultrasound abdomen was done. It showed minimal ascites, and the liver, spleen, kidney, and prostate were found to be normal. This is the picture of the ultrasound abdomen of the patient. Next, an echocardiography was done, which revealed normal size of the left ventricle, normal function of the left ventricle. There was hypokinesia of the anterior septal wall, mild hypokinesia of the inferior wall. There was large loculated effusion lateral to the left ventricle and anterior to the right atrium, right ventricle. There was a partial right atrial collapse. There was no right ventricular collapse. The ejection fraction was found to be 61%. This is a picture of the echocardiography. As you can see, there is an effusion, pericardial effusion is seen.
This is the large area of effusion.
It's very clear in this picture.
It's compressing the RA. Area is diffusion. It is a loculated diffusion of different pockets. 2-3 pockets are there in throughout this, and that is compressing RA and partially RB. So now whole thing is that what the cause remains, the stigma remains, that what is the cause and how to relieve them. After this, seeing this pocket, we have routinely gone for the investigation, and surprisingly the findings are.
On further investigation, HbSAg and HbA were found to be non-reactive. And on HIV test, the HIV kit test and ELISA both were found to be reactive. So we went further for a flow cytometry, and the CD3 count was found to be 1250 per cubic millimeter. Coming to the CD4 count, it was reduced 202 cells per microliter. The CD4-CD8 ratio was found to be 0.2. This is the picture of the report of the flow cytometry done at Chennai. Coming to the drug resistance assay, the patient was found to be susceptible to all the NRTIs shown here. It was also the condition was found to be susceptible to all the NRTIs shown here. This is the picture of the drug resistance assay report of the patient. On final diagnosis, the patient was found to be a case of HIV infection AIDS with a loculated pericardial effusion in a background of post-CABG with diabetes mellitus.
Then the whole thing is that HIV with pericardial effusion, stage 4, 3 and 4 mercury, it is an advanced stage. And then on so many times of taking the history, you are not giving the history of contact. Family action, I have no contact history. Then he received 5 bottles of the blood for during the time of bypass surgery. That one culprit, and second, that he is not divulging the source. These are the two possibilities, but how to relieve them? It remains us. Either it was a loculated this, so pericardium by great effort it has been drained. It started in view of high protein levels and followed by the antiviral therapy. Now his whole pictures will just show that.
And coming to the treatment, a pericardial synthesis was done, anti-tubercular treatment was started, the cotrimoxazole prophylaxis was continued, and the antiretroviral therapy was started after 4 weeks of anti-tubercular treatment.
And after ATP of this, again echo we have done it. Whole pericardial pockets has gone now. The picture is here.
A post-treatment echocardiography is the picture.
There is no infusion. A very negligible thin amount of this. Whole has gone. Patient is working now. Today we want to invite them, but due to this diagnosis, we are not HIV. We don't want to divulge in front of them. That's why we avoid them. Otherwise, he is very much willing to come to attend this function. So it's all right now, and we are continuing for the antiviral therapy along with this.
I think perhaps we are dealing with what is called constrictive variety of the pericardial effusion, because there was some constriction in the bands, as you mentioned, and perhaps it was tubercular. Now, a lot of enthusiasm arose some time back about the HIV infections of the cardiovascular system. Lot of concern was like HIV causing myocarditis or cardiomyopathy, and HIV infection causing even in health stage pulmonary hypertension. One of the important causes has been mentioned as HIV infection. So HIV infection has spread its spectrum of presentations. And as you rightly mentioned, that the patient had not only a cardiovascular problem but also an infective problem in the form of HIV infection with tuberculosis. Because HIV per se, I think, will not give rise to such sort of banding. And Yotima is here, perhaps he can enlighten on that. But I think that this is a very interesting case, and one should always take history of HIV infection. I think that's very important, particularly background of CABG, etc., etc. That means even a elderly person, we have to take that history when you have got any history of operation.
HIV, regarding HIV and heart, we have got 3 in last 10 years, 3 patients. I remember one patient came with VPC, ventricular premature complex, regularly from Raurkela. We have admitted them in ICU for 3 days for treating this. Only for the VPC we have given for anti-arrhythmic treatment, and routinely when we sent them for with this HIV was positive, and within 7 days when he was attending in my bathroom, hospital bathroom, he felt and collapsed and finally died. So HIV involvement of cardiovascular system is a bad problem. This message is very clear. That once it is involved, we have to having very bad. Yeah, commonest is the HIV cardio. One case we are having. 3 cases we have seen HIV.
You have mentioned that ART should be started after 4 weeks, but it should be started as early as possible.
We have
within 2 weeks.
The CD4 count is 200, less than 200, then the ART should be started between 2 to 8 weeks after ATT. If it is more than 200, then heart can be started after 4 weeks. And if the patient is well enough and the CD count is well high, then you can start the heart after intensive therapy of ATT.
This is a stage 4.
It is a stage 4.
Extra balloon.
It is extra balloon. Stage 4. You have to start the heart
as early as
after
possible after stabilization.
Now research recommendation for all stages, particularly stage 4, stage 3, it should be started as soon as possible, even before.
But as per NSCP 4 guideline, it should be wait up to 2 weeks. And it's a very different with NSCP 4 guideline.
We are going to with sensitivity we have got it.
Here you should not start the nevirapine instead of you should use the efavirenz. That is very important. Along with this rifampicin.
Any scope of pericardiectomy?
Yeah, again, once lobulated, it has been vanished, already gone. We have a plan for electrothoracotomy and complete correction, and if necessary, pericardiotomy is the only choice if it is the recurrence. But HIV, after HIV, whole plan we have changed. Because of the again for going off huge operation. Prognosis is, you know, is a stage 4 AIDS, the prognosis is very guarded. So we have the conservative treatment and he is doing well with well shown visual. And all the symptoms, he was so much symptomatic you can't explain. So all the symptoms have gone. Steroid may basically ATT plus HIV and plus antidiuretics, all anti-inflammatories. That is where it comes. Thank you.
Thank you, Dr. Jha.